So basically today I want to talk about taking the guesswork out of stepped care. Biomarker-based stratification to RTMS and antidepressants and show you some new insights there. Here are my disclosures. I'm an unpaid research director at Brain Clinics Foundation, which is also a non-profit, and I have several advisor and shareholding opportunities, and Brain Clinics has received funding from various parties as well. But in my view, that should not distort the information I'm conveying here. Okay, so when we talk about precision psychiatry, I think it's a very hot debated topic that many people are publishing on, many people are doing research on. But unfortunately, I think, as many of you know, we're still pretty much stuck with the one-size-fits-all model. So what I want to do in this next 30 to 40 minutes is explain a little bit to you where I think precision psychiatry could be a real nice focus for the future, but maybe more realistically speaking, for most of us that are still being clinicians and treating the single patient that walks in the door, that maybe stratification could be a better alternative to consider, more easily implementable in clinical practice. As examples of treatment stratification, I will give you a little bit of an update on the neurocardiac guided TMS or heart-brain coupling, but also I want to focus on cross-treatment prediction of outcomes using EEG. But first I really want to focus a little bit more about what's the core of the problem, what is going on with precision psychiatry, and where would stratification fit in, and where is it really different or maybe the same. So on the one hand, on the left-hand side, we see that we're pretty much stuck in one-size-fits-all psychiatry. We have a DSM or ICD-9 or 10 defined diagnosis, for example, depression. We apply a therapy from the antidepressant family of treatments, which can either be RTMS, psychotherapy, or drug-based treatment. And in the good event, we get a benefit with the patient. Some people simply do not respond, and some people cannot respond due to adverse side effects and adverse events. So actually what everyone is dreaming about, including myself, for quite a long time now, is that we really want to move forward to a future of precision psychiatry. And precision psychiatry meaning that on one hand we want to take more advanced biological metrics, maybe combined with clinical metrics, combined with genomics, and using that mix, being able to really individualize a treatment to the individual person. So that requires, in the ideal world, a lot of individualization that is not automatically tied or associated to a clinical diagnosis as we know it today. So it could hypothetically implicate that a depressed patient might best respond to Ritalin, which nowadays would still be hard to conceive, to offer and consider that as a first-line treatment. So I'm taking this example because I think it's a very well-known study to many of you. I'm not saying here that this study is true or not. I think it's good for you to look up the Dinga et al. Non-replication of the study as well. But I just want to use this study as an example. So let's assume, for the sake of the argument, that this study was one of the first ones to really report a biotype model that could have implications for TMS treatment response. Now we know that in this dry still study they have taken many fMRI scans, and using a very complicated procedure they came out with 4 different biotypes. So what we see when we port those biotypes to TMS treatment, and this is TMS treatment to dorsal medial prefrontal cortex stimulation, that we see 2 biotypes are showing very high response to TMS, 60 to 80%, and actually biotype 2 and 4 are showing a relatively low response to treatment. So let's now assume that this is completely validated, ready for prime time in clinical practice. Then I'm asking you as a clinician, what is the implication when you get a patient with biotype 1? Well, you'll say, well, that's very simple. Biotype 1, I congratulate the patient. He can go home and get the treatment because the response likelihood is 80%. But what now if your patient comes back as a biotype 2 or 4? Can we then continue the treatment given the relatively low likelihood of responding, or should we deny this patient the treatment? And that is really where I think the ethical dilemma comes in. Because is it ethically allowed to take a very severe patient, maybe suicidal as well, and deny someone a treatment based on this type of research, whereas we know that if we look very carefully, the likelihood of response is 25 to 30%. So that's not zero. And it will never be zero. I think there will not be biomarkers that have such profound prediction capacity. So I think this is really where we have an issue. As long as we do not have an alternative to offer to the biotype 2 and 4 that at least have been validated as treatments for depression, I think the perfect future of precision psychiatry is going to be quite difficult. And that's why I think a kind of a blended model in between, which we refer to as stratified psychiatry, could be more realistic for the tomorrow's clinical practice. So with stratification, I mean that we are not simply granting or denying a treatment based on a biomarker, but that we try to find out which treatment someone preferentially will respond to relative to another one, by still remaining within a class of treatments. So I'll take you through a little bit of a kind of simulation or a kind of overview throughout the literature. And in the following, I will show you many studies, especially the largest scale studies we have been able to come across, either the largest meta-analyses or the largest non-industry sponsored trials, to give you a little bit of a flavor of how we conceive of this. So this is a very big meta-analysis by Pim Kuipers from 2014. And in this meta-analysis, he reported the response and remission rates of various types of psychotherapy. So we see cognitive behavior therapy, intrapersonal therapy, and other. And we see the NS implicating there's not a significant difference in response and remission rates between any of the three antidepressant psychotherapies. So let's now switch to our own field. Here we see TMS. This is the very well-known Bloomberger trial, and even though we know that both 10 Hz TMS as well as intermittent theta burst stimulation came out as very effective in the treatment, there was no significant difference between those two treatments. The only maybe advantage would be that ITBS is a bit quicker. So again, not a significant difference between two different classes of RTMS. So let's now move to medication. And here we see basically the clinical response and remission rates mainly to first-line antidepressants as were reported in the iSpot-D trial. And here as a frame of reference I've also included the first line of the STAR-D trial. And again we see not a significant difference in response and remission rates between three very often prescribed antidepressants. So Pim Kuipers, in one of his meta-analyses, also demonstrated there is not a significant difference between psychotherapy on the left-hand side and first-line antidepressant treatments on the other hand. So looking at this whole landscape of treatments that we have available in the treatment of depression, I think we can conclude that we might as well roll the dice and assign someone to any of these treatments. That's literally what happened in the Bloomberger trial, but also in the iSpot trial. Patients were randomized to one or the other treatments, and based on the group level response, and note that I'm stressing the group level response, we see that the likelihood of clinical response is pretty much similar across treatments. So if we roll the dice, we could, for example, conclude that someone's response to 10 Hz TMS is about 30 to 45% for response and remission. But for someone else, we roll the dice and we say, well, citalopram will give you, again, like 30 to 40% likelihood of response and remission. So the thought experiment I want to take you on with is, well, if we could roll the dice, if you will, in order to assign someone to a treatment and not do any harm, which I think the fundamental principle we need to listen to, could we also then maybe rely on a biomarker to assign someone to one of these treatments? And hopefully, the worst case is that it will be identical, but in a good case, we might expect better response and remission rates. So would that be ethically permissible? So that is, in a sense, what I'm referring to when we talk about stratified psychiatry. So here I want to focus a little bit more on mapping the frontal vagal pathway, which is many of you have heard of, also labeled as neurocardiac guided TMS. I want to start out with a little bit of an animation. And so what we have, what several studies have reported now is that when we stimulate specifically the dorsolateral prefrontal cortex in an individualized manner, we know that there's transsynaptic activation of the vagal nerve, which has now been described in various ways. We now understand that basically via the dorsolateral prefrontal cortex, we are also transsynaptically activating the subgenuine anterior cingulate, which is mediating the vagal response and also resulting in specific sympathetic activity that is now also reducing heart rate activity. That's what we mainly measure with the NCG-TMS, but also we see an increase in heart rate variability and decreases in blood pressure. Just to orient you a little bit more, over the last couple of years, there have been various replications of this work. We can see here the work of our Australian colleagues from Paul Fitzgerald and Marina Kaur, who independently replicated the NCG-TMS finding. We, on the right-hand side, see the most recent publication by Tabitha Isager, where she also looked at many more prefrontal sites, and most specifically found the heart rate deceleration to take place at FC4 and F4, which could also be the inverse on the left-hand side, but specifically those two areas, which we initially reported as well. And a recent meta-analysis based on individual participant meta-analysis also confirmed the effects to be there, and there were no laterality differences between the right and the left hemisphere. And so I think we can really consider this a well-established finding right now, especially when focusing on 10 Hz. Interestingly, Paul Fitzgerald recently published a new kind of review, where I think he did a pretty good job on putting together the different clusters and the different targets that are currently used throughout the TMS literature. And I think conceptually, when you read it quite carefully, there can be seen a kind of 5 centimeter cluster where various targeting methods are ending up, and also the beam F3 cluster. In a sense, I think when we look at all the literature around, there's currently no head-to-head comparison. So I think we cannot conclude that one target on the group level again is better than the other targets. We see the effectiveness data from the Bloomberger trial, which is more focusing on the beam F3 cluster. And we also know the open label data from the Carpenter trial, which has quite similar outcomes as well, which has been targeting the 5 centimeter cluster. So on the group level, at least, I think we can safely conclude that we would not expect huge differences in clinical response and remission rates for either target. When we look a bit further, here we see the MRI imaging method that's based on the subgenuine anterior cingulate anti-correlation, as first proposed by Pasquale Leone and Michael Fox. Then we see that the area that is actually lighting up for most of the individual patients is also quite well scattered around both these areas as well. And I think in line with the NCG-TMS findings, both in MDD patients and healthy controls, and we see a similar area that's lighting up. So that's really asking the question, can we utilize this methodology as well to individualize people on an individual basis to one or the other sites? When we looked at this a little bit further, here we see some additional data where we also compared NCG-TMS to NCG-ITBS, or using ITBS to map basically what's happening with the heart rate activity. And on the one hand, we saw that ITBS was able to elicit a much stronger heart rate deceleration relative to 10 Hz. But on the other hand, when we look at the topography was completely different. We saw that there were more lateral sites that were actually showing the largest amount of heart rate deceleration, both across the groups, but also if we look at within subject analysis for people that both underwent the 10 Hz as well as the ITBS. And so this is really a completely different kind of loading that we're seeing. In addition, we also witnessed many more adverse events by using the NCG-ITBS, 5 out of 30 healthy people, whereas none such side effects were reported with the 10 Hz TMS. So therefore the conclusion we drew here was that for the time being, I think with this approach we need to focus on 10 Hz, and we need more research to focus on the ITBS and understand that mechanism a little bit better. Still, we wanted to improve on this method, so we want to improve the sensitivity, because we know that with ITBS we can elicit about, on average, 8 BPM of a change on the group level, which was only 2 BPM for the 10 Hz method. So therefore we have now resorted to the 10 Hz DASH protocol, where actually we can use an 11-second intertrain interval, which has been found to be safe and also FDA approved. But actually it will allow us to basically apply more stimuli within a given minute. So it's almost doubling the stimulation rate. Furthermore, in our research, we now want to focus on stratification, knowing that all the other sites outside the beam cluster and the 5 centimeter cluster were showing heart rate acceleration. I think focusing on these clusters make more sense. And very importantly, the prior studies found no correlation between cardiac response and motor threshold. So this implicates that we really need to start investigating in more detail frontal thresholding rather than relying in a blinded fashion on extrapolating the motor threshold to the frontal cortex. I'll show you some data of that. So I think we would now want to focus a little bit more on the brain-heart coupling with a focus on variability, and that's also summarized in this picture from a study that we already published using ITBS, where 3 minutes of ITBS in a real versus sham, we see to begin with the deceleration of the heart rate that we've described before, but what we have not reported on too much is that we also see a huge increase in heart rate variability. And so there's much more rhythmicity induced over a longer time period as a result of the ITBS, which is not as much present in the sham conditions. So this is very recent work. Actually, I received this this week, these data, so it's brand new data. And this is a new method that we're currently testing, where we are actually, on an individual level, we see here the beam F3 left cluster, here the 5 centimeter left cluster, the beam F3 right cluster, and the 5 centimeter right cluster. So you can view this from the top as being your right-left, and also the more anterior versus the more posterior cluster. Secondly, we have now applied a TMS sweep, meaning we applied 4 trains of 10 Hertz with 11 second intertrain interval, which we were ramping up from, in this case, from 33% of machine output, 35, 40, etc. And we have centered this that the motor threshold of the individual would always be the 5th intensity, so we would have 2 steps above the motor threshold and also about 4 steps below someone's individual motor threshold. So here we see the RR intervals, like we've seen before in the previous picture. And in this example, you can see that there's a nice respiratory sinus arrhythmia, but the heart rate variability is tremendously increasing when the dose is increasing as well. We see it in this individual most specifically for the beam F3, as well as the 5 centimeter on the right. So interestingly, we can also see a kind of asymmetry within a subject, that if you want to do left TMS, it's better to focus on the beam, and if you want to do right TMS, it might be better to focus on the 5 centimeter. Most importantly, what we see as well here, we see the spectrogram, which is giving you the spectral content or the frequency content of the RR intervals. And here we can see that already below the threshold, we can see that the cardiac response was already taken place. And so this is 5% actually below the motor threshold, so about 90% of the motor threshold. And a similar kind of picture we see here on the right hand side, and much less clear of a picture on the other sides. Let's now go to a second subject. So this was quite different. And we see the exact same layout again for example 2. But now we see for this subject it was most specifically for 5 centimeter on the left. But secondly, the motor threshold for this individual was at 40%. We can again see a slightly increased variability, but the variability here in the spectrum was already starting to show around 30%. So that is actually 10 machine output points below the initial threshold. So this is about 80% of someone's motor threshold. We see that the frontal vagal pathway is already responding. And so we've seen more examples like this. So I think we here see a nice approach where we can both index what the right stimulation location should be, as well as establishing someone's individual threshold. And in the next example, I think it will also become clear why it could be so important. So in this subject, we actually found that during our piloting phase that there was this one subject that actually experienced a syncope. So we saw that while we were applying the first round of stimulation at the beam F3 on the left-hand side, we saw that the motor threshold of the individual was actually 60%. But we already saw that about 15 percent points of the machine output below, we saw the first initial cardiac effects taking place within this specific frequency range. So that actually implicated that the frontal threshold was about 45%, which was 75% of the motor threshold. remember that when we look back at these pictures, we see that I drew a line here, that the heart rate, reflected with the blue line here, was actually very stable across the whole recording period. And so it was actually the deviation from the around the heart rate that was being picked up. What we see in this subject was, even though the heart rate was starting around 80, we saw that there was a decrease in heart rate, which was decreasing from about 80 BPM to here it dropped even below 60 BPM. So I think what we can see here is that on the one hand the heart rate was going down as a function of stimulation. It was so low, actually at a level that the subject had never seen last month after inspecting her Fitbit heart rate data. And so actually we can conclude here that we were overstimulating this individual by relying on the motor threshold, where actually we saw that we should have been relying on a frontal threshold, which could have been found at a much lower intensity. And I think this also opens up potentially the discussion that is a syncope a specific or a non-specific side effect of RTMS. I think it can often be non-specific as well as a result of tension and anxiety for the procedure. But I think here we have a case that we can really conclude that by understanding the frontal vagal pathway and understanding that some people actually get overstimulated when we actually measure the frontal vagal response, that we can get an overdrive in the system whereby we see the heart rate responding too heavily on it, actually causing someone to go into a syncope and a polyvagal and showing this polyvagal response. We can also see that the heart rate variability actually increased, so it's not automatically tension mediated, because if the tension would be taking over, we would have expected a lower heart rate variability for this subject. So my question to you, and we can discuss that maybe in the Q&A as well, has any one of you experienced syncopes in other than DLPFC targets? And what would be the likelihood? I mean, it might well be that this mechanism helps us understand how a syncope is caused, but also how to deal with it more efficiently, and also is, I think, making a good case that we need to start relying on frontal thresholding as well. So that's basically for the frontal vagal pathway. So let's now switch gears a little bit and start looking at how we might be able to utilize the EEG as a treatment stratification tool for taking the guesswork out of a stepped care model. So the EEG is something that we measure on the cortical surface, and we can see on the left-hand side that various differences in neural firing can actually show us different types of activity on the scalp. So when we know that the brain is processing all kinds of information, we see low amplitude, fast frequency activity, and this is more when we achieve drowsiness, when the brain starts more firing in the burst firing mode, we see more EEG activity that shows a much slower frequency content, but also a much larger amplitude. And so this is also what the setup looks like, how we assess a quantitative EEG by wearing a cap and submitting someone to standardized procedures. So we'll briefly touch upon this study. I've presented these data several times, but I briefly want to highlight 3 of the pivotal findings that we have been able to report on this, in my view, the largest biomarker study that has been conducted so far. And so the iSpot-D study has included about 1,008 patients that were randomized to 3 well-known antidepressants, and we also collected data from many controls. So the 3 main biomarkers that we have reported on before, we have reported both drug-specific effects, we have also reported sex-specific effects, as well as drug class-specific effects, and we see one example of each in this picture. So on the left-hand side we see the first biomarker that we reported, which was the frontal alpha asymmetry, which was only valid for females. So there were no effects to be found for males, so this is a drug class specific as well as sex specific biomarker, where we find that people with a more left dominance in frontal alpha would be less likely to respond to an SSRI, namely escitalopram and sertraline. And when people would have a more right frontal dominance of alpha activity, they would be more likely to respond. But interestingly, we saw no such differences for venlafaxine, which is an SNRI, as well as for RTMS. So we know it's a specific predictor for some treatments, but not for every treatment. Then when we look at different predictors, here we found IED, which is the presence of epileptiform activity, which often is present in patients with epilepsy. But of course, these were not epilepsy patients, but depressed patients. And we saw that those patients that were showing signs of epileptiform activity were actually showing a 3 to 3.5 lower likelihood of responding to treatment. But interestingly, that's only for escitalopram and venlafaxine, but not so for sertraline. And then the third marker that we looked at, which was the alpha frequency, and we see with alpha frequency, we see an opposite pattern, that the slower the alpha frequency, the more likely someone is to respond to sertraline. So taking these findings into account and what I've demonstrated before, we could as well randomize people by throwing the dice and assigning someone to a treatment. But we could also say, like, well, why not start applying this in a prospective fashion? Because I think the strongest causal evidence we can find is a prospective trial where we actually prescribe medication based on the EEG. And that's exactly what we've attempted in this open label feasibility trial, where we wanted to also test feasibility, like with the question, can psychiatrists or are psychiatrists open to prescribing medication that is derived from a conclusion based on the EEG? And that answer was a full yes. It was very well received by the psychiatrist in this trial. And here we constructed a very simple decision tree based on the prior biomarkers we've seen. So we inspected if the EEG was abnormal, if there was epileptiform activity. If the answer was yes, we prescribed them with sertraline. Then the second level was inspecting their alpha frequency, and if it was too slow, we would also assign them to sertraline. Then we stratified based on sex, so males would automatically get escitalopram, and because the frontal alpha symmetry biomarker was specific to frontal alpha symmetry, we would stratify them to an SSRI or SNRI based on the frontal alpha symmetry finding. So interestingly, what we found, and we did not expect this because it was just a feasibility trial, but by comparing 52 people that underwent treatment as usual or prescription by the psychiatrist, contrasting that to those patients that were submitted to a treatment by EEG-informed prescription, we saw a significant improvement in the change on the symptoms of the patients. And actually, when you look at the remission rates, we see that remission rates almost doubled for the EEG-informed group. So actually, this very favorable results that we already saw inspired us to start diving a bit deeper and scaling this up to some degree. So currently we are mainly focusing on developing brain markers, but up to such a level that we are really able to work with clinically actionable brain markers that we can start applying in practice. As similar to knowing now that we have a blood pressure, and if your blood pressure is above 130, that's probably something to be watchful of. And if it's below, that's considered to be in a normal range. Along the same lines, we need to work on EEG, making it clinically actionable and more understandable for people as well. So we've started with brain marker 1, which is actually the alpha peak frequency, which we have found across disorders to be a very powerful predictor. So to begin with, we have applied 108 different permutations of calculating alpha frequency, and we can use different segment lengths, different EEG montages, so there's a lot of ways to calculate alpha frequency. So we've been validating this on a large data set of over 4,000 patients that we have collected EEG from, and we have validated the alpha frequency against the ground truth scenario of brain maturation. And we can see that visualized here. Here we see age and the alpha frequency, and we know that when you're maturing up till adulthood, that your alpha frequency speeds up, and then it remains relatively flat, whereas in later life it starts decelerating again, which might also be driven by some people with undetected Alzheimer or mild cognitive impairment. So what we then do is the next step. We then very contemporaneously, with these times of COVID, we were flattening the curve, but then not in COVID sense, but more in alpha frequency sense, that we really try to age and sex normalize this curve that we described here and made it a flat curve whereby we could get a deviance or a divergence score for every individual, and then we ported these to decile scores for enhanced interpretability. So now the question is, this brain marker that we developed, which took quite a bit of time to run all the permutations and the analysis, we've picked the 2 top candidates and start further validating those in the treatments that we've been looking at. So when we now look at ADHD, we had already observed and found that there's an opposite pattern for alpha frequency for methylphenidate, where we know that a faster alpha frequency is associated with good response to methylphenidate, but actually to poor response to neurofeedback. So based on what those data that we published before, we prospectively applied the brain marker that we developed, and we assigned people with a relatively high score to methylphenidate. Sorry, these numbers are the other way around. So people with a high frequency were assigned to methylphenidate, and with a low frequency to neurofeedback. And then actually we see when we do that exercise that remission rates in the stratified group relative to the overall remission rate of the full group would have been enhanced with 17% for methylphenidate, and we see a 30% enhancement for neurofeedback. The atomoxetine was more a exploratory question, and we see a slight improvement there as well. So now the question is, the $1 million question, if we now would take a large sample of about 100 people, would this replicate out of sample? And therefore we reached out to Sandra Liu from UCLA, who has a lot of data on EEG and treatment data after methylphenidate, and she was kind enough to share with us the EEGs only. So we were blind to treatment outcome. We only knew someone's sex, someone's EEG, and someone's age. And using those 3 ingredients, we made predictions of who would have achieved remission and who did not achieve remission. So then the question is, how well did we do? Well, to my surprise, we actually did better than on the discovery data set. We saw actually that the remission rate was enhanced with 36 to 36%. And so we see that with a blinded out-of-sample validation, we can confirm that the biomarker is predicting response. But again, we're not triggering here a life or death decision. We simply are able to stratify someone to methylphenidate if they have the right direction of alpha frequency. If not, we will assign them to the alternative of neurofeedback or maybe atomoxetine in some cases. And so I think this is, a very nice example where a single biomarker, not factoring in any complex other elements as well, but simply focusing on one biomarker, we can already assign someone to the right treatment. So here you think, well, what can we do for depression? Well, the same marker has also been reported to have an association to treatment response in RTMS, especially to 10 Hz TMS. So Andrew Leuchter's group, together with Juliana Collier and Linda Carpenter, were the first ones to really report that the association is not like a linear association, but it's more a quadratic relationship. So the closer someone's endogenous frequency is to 10 Hz, the more likely someone is to respond to 10 Hz TMS as well. So we found this really interesting. So with the ICON DB consortium, we set out to replicate that finding. And interestingly, we were indeed able to replicate the finding. And here we see that for the individuals, that the closer their alpha frequency gets to 10 Hertz, the higher the percentage of change we saw after 10 Hertz TMS. And a tapering off beyond 10 Hertz, which was not driven by the outliers you see here. So it's an independently replicated finding, and it was specific to 10 Hz and not specific to 1 Hz TMS. So that triggers the question, can we take this ground truth scenario right now in order to stratify people between different treatments in depression? So that's exactly what we're currently working on. We've again taken the brain marker, the way we've developed it against this ground truth scenario. And if in step 1 we would apply what we call the synchronization marker, which tells you that someone has an alpha frequency between 9.6 and 10.4 Hz, and if we assign them to 10 Hz TMS, we see that the remission, this is the observed remission for the group, but the remission is enhanced by 24%. If we look at the 1 Hz group, which we know was not a significant finding from the prior studies, there's a slight enhancement, but not as much as we see with the 10 Hz TMS. So the first step would be we take an EEG. When the synchronization marker is hitting a green light, then you assign someone to 10 Hz TMS. Now, in a second step, we wanted to look at if we still go back to the decile scores from 1 to 10, is that in any way informative in assigning someone to escitalopram, sertraline, venlafaxine or 1 Hz TMS. And here we see the results for females and males separately, because often, remember, we see sex-specific effects as well, and mainly focus on the divergence between the blue and the green. The blue meaning that's the low alpha frequency, and green meaning the high alpha frequency. So I think if we first focus on the high frequencies, for females then the best choices will be escitalopram and venlafaxine, and for the low frequencies, that specifically is a very hard to treat group, but there sertraline will be a good choice, but for males it will be sertraline or venlafaxine. So this is very preliminary data. We are still working on this further, but I hope you can see a picture emerging that will be quite similar to what we have seen for ADHD, where we can really help stratify patients to known effective treatments by still taking the EEG into account. So therefore, I hope I have shown you and hope convinced you that what I think stratified psychiatry could be a great stepping stone on our way to precision psychiatry. I still think we need to do a lot of research on precision psychiatry, but stratified psychiatry is something that we could start applying in clinical practice relatively soon already. So the outlook, I will quickly skip over this, but there's a couple of more advanced analyses we're using as well. One of them is artificial intelligence and deep learning, where we already successfully applied that to predicting someone's sex, which is something we cannot see, but also we're applying that prospectively to beta spindle classification, and we are currently seeing if the model that we developed here for sex prediction, if that also generalizes with transfer learning to predicting treatment response, which there might be some good chances there as well. So I want to come to my conclusion. My conclusion is summarizing that I think stratified psychiatry is more realistic for clinical practice. I've shown you several examples of drug-specific, drug class-specific, cross-treatment and transdiagnostic examples of biomarkers. Prospective EEG-based stratification is feasible, as we concluded from the feasibility trial, and was showing very promising results as well. And I think with brain marker 1, I think we have seen an example of a first clinically actionable transdiagnostic validated biomarker in ADHD and also in depression, what we'll be working on further. Next year I hope to be able to show you brain marker 2, 3, 4, etc. So of course we'll never have a boring moment, so we'll keep on focusing on investigating more biomarkers to complement the family and get better insights for patients. NCG TMS using 10 Hz is a well replicated and robust finding. The ITBS finding needs further research, and I hope to also have shown you a little bit of a peek insight into the heart-brain coupling method that we've now been looking at, which can help you in site selection between the two clusters that we've seen, but also I think even more promising, it might be an aid in helping you with frontal thresholding, but that's to be continued. With that, I want to also thank the whole team that we've been working with and many of the collaborators we have. We have many people that are taking a chunk of the research that I've been demonstrating to you. I'm just the only one sharing the message with you, but believe me, there's a very large team behind it who all deserve credit to all the results that I've been showing so far. So thank you for your attention.